Can you scuba dive on blood thinners? You know, it's funny, this is actually one of the absolute most common and definitely most anxiety-inducing medical questions that divers ask all over the world. If you or a buddy are navigating this right now, you know exactly what I mean.
Welcome to this explainer. I kind of like to think of today's session as your ultimate comprehensive pre-dive briefing for anyone who's dealing with this exact medical dilemma. We're taking the latest medical guidance and transforming it into a straightforward learning guide. I'm going to walk you through exactly what the risks are, what medical professionals actually look for, and how to figure out if you can safely get back in the water.
Okay, let's literally dive right into this. Our plan for today covers the blood thinner dilemma, 5 major diving hazards, medications and conditions, assessing your dive profile, and finally, post-dive red flags.
Starting with Section 1, the blood thinner dilemma, setting the baseline.
So, there's this really pervasive myth floating around the diving community that the second you get prescribed a blood thinner, you literally just have to hang up your fins forever. No way. The truth is, taking anticoagulant medicines doesn't auto-disqualify you from scuba diving. It's really more of a yes, but situation. We have to look incredibly closely at your specific bleeding risks, the consequences of potential injuries, and how stable your actual medical condition is on an individual basis.
And this brilliantly illustrates what we mean when we say blood thinners. We're talking about common anticoagulants like Warfarin, Apixaban, Rivaroxaban, dabigatran, edoxaban, or heparin. On land, these artificially slow down your body's ability to form clots, right? They're absolute lifesavers. But underwater? The crazy irony is that these land-saving drugs become your biggest underwater hazard. They completely change the game. See if you can spot your specific prescription on that list.
Moving on to Section 2. 5 major diving hazards. The pressure cooker.
Right, so we're basically taking these medications into a giant pressure cooker. There are 5 main interconnected hazards here. We've got bleeding after barotrauma, a greater danger from DCI, trauma risk during everyday dive activities, the underlying medical condition itself, and of course, remote location concerns. Let's break these down so you understand exactly why the pressure matters so much. First up is barotrauma. Simply put, this is tissue injury caused by the pressure changes of diving, affecting your ears, your sinuses, your lungs, or even just your mask. For a healthy diver, a mild ear squeeze might just be a bit annoying, but for an anticoagulated diver, even minor barotrauma can lead to extensive bruising or serious internal bleeding.
And here's why this matters in a totally life-or-death way. If you suffer barotrauma that causes bleeding into your middle ear, it can trigger severe vertigo and disorientation while you're underwater. A simple ear squeeze for a normal diver? Well, for someone on blood thinners, that suddenly transforms into a massive drowning risk.
Hazard number 2 is decompression illness, or DCI. If you get bent, anticoagulants complicate absolutely everything. The tricky part here is that neurological DCI can actually look exactly like bleeding within the brain or spinal cord. That makes diagnosing and treating it incredibly complex, and it can increase the severity of bleeding in injured tissues.
But hey, let's remember the danger isn't just underwater. Think about routine trauma risks. We're dealing with hauling heavy cylinders, climbing unsteady boat ladders, slipping on wet decks, shore entry falls, or getting battered by currents. A seemingly minor knock to the head on a slippery dive deck could cause a serious intracranial hemorrhage if you're on blood thinners.
All right, Section 3, medications and conditions, the medical assessment. So assessing your fitness to dive isn't just about looking at the pills. The really crucial point here is that the underlying reason you're taking the prescription is often a much bigger hurdle to safe diving than the actual medicine itself. We have to look at your actual physiology.
These are the common conditions requiring anticoagulants. Things like atrial fibrillation, deep vein thrombosis, pulmonary embolism, artificial heart valves, a stroke history, or various clotting disorders. The reality is, these conditions can independently cause sudden incapacitation, slash your exercise tolerance, or increase embolic events.
Let's contrast 2 scenarios to really make this clear. If you have stable AFib and great fitness, you might actually potentially dive safely after a specialist assessment. But if you're dealing with an unstable cardiac disease or recurrent emboli, you just might not be fit to dive at all, regardless of how well your medication works. The boundary between a medically sound dive plan and an automatic disqualification is all about baseline stability.
Now, what's really interesting about this slide is the comparison between warfarin and DOACs, direct oral anticoagulants. Warfarin is infamous for INR instability, drug and diet interactions, and a higher intracranial bleeding risk. DOACs, like Apixaban, on the other hand, have a much more predictable effect, a lower intracranial risk, and 0 INR monitoring.
Just remember, serious bleeding risks remain for both classes of drugs.
Section 4, Assessing your dive profile. The dive plan.
Let's bring this into practical application. I'm talking directly to you about your buoyancy control and personal dive choices. This table contrasts high-risk situations, like poor buoyancy control, forceful equalization, deep or deco dives, cave, wreck, or solo dives, and uncontrolled hypertension. Pushing limits multiplies the medical danger exponentially. On the flip side, acceptable situations are built on conservative profiles, excellent equalization skills, good exercise tolerance, a totally stable underlying condition, and absolutely no recent clotting or bleeding.
Think of this as your ultimate safe diving rule set if you're cleared to dive. The recommended restrictions usually include absolutely no decompression diving, sticking to conservative depth limits, avoiding overhead environments entirely, skipping strenuous diving, always diving with experienced buddies, and ensuring careful hydration and thermal protection. You're shrinking your margin of error, so you have to shrink your risk exposure.
Finally, Section 5, Post-Dive Red Flags, Surface Protocols. You know the drill. The dive isn't over until you're safely back on the surface. Treat this as an emergency surface protocol checklist that every diver and buddy must memorize. You absolutely must seek urgent assessment for things like a head injury, severe ear barotrauma, coughing blood, any neurological symptoms, severe bruising, a persistent nosebleeds, sudden breathlessness, or unusual back pain. Deliver on this protocol with urgency.
And before you even think about packing your gear, I want you to remember this quote. Fitness to dive should ideally be assessed by a doctor experienced in diving medicine, such as the UK Diving Medical Committee or Divers Alert Network. Standard doctors might be great, but they often don't understand complex dive physics. Consulting specialized authorities is completely non-negotiable. To wrap things up and summarize what we've learned in this explainer, diving on blood thinners isn't an absolute no, but it absolutely magnifies the consequences of a mistake. The major concerns we've covered today are bleeding after minor trauma, DCI complications, head injury risks on the boat, and most importantly, the underlying medical condition itself.
So, I want to leave you with this one provocative question to really think about. Based on your underlying condition and your actual in-water skills, is your current dive plan truly conservative enough? Give that some deep self-reflection before you ever zip up your wetsuit. Thanks for joining me on this explainer. Dive safe out there, and I'll catch you on the next one.